The next session will still be on endourology. Co-moderating with me is Dr. Besut Daryanto, who will be moderating virtually from Indonesia. And the first speaker is none other than Professor Oliver Trexler, who truly needs no introduction. He will be talking to us about the use of flexible urethral rhinoscopy for upper tract TCC. Over to you, Prof.
Good morning, everyone. My disclosure for this talk. So now we will talk about the conservative treatment of urothelial tumor. I think there's no need to come back on this statistic regarding epidemiology that you probably know. It represents 5 to 10% of urothelial carcinoma, but it's regularly a challenging issue. We all know that the gold standard treatment, when we have to treat a urothelial tumor of the upper tract, is still the radical treatment. So I mean the nephroureterectomy. But we know since sometimes that there's some alternative possibilities regarding endourology. It's possible to treat some of the tumor percutaneously or by using more and more the retrograde access. Actually, the guidelines recommend to do percutaneous surgery only if it's not feasible retrogradely. You need to consider then PCNL. Role of endoscopy is very well defined actually, and diagnostic ureteroscopy together with biopsy should be performed, especially in case where additional information will have an impact on the treatment decisions. Just to show you some example, you see on the left we have a filling defect in the lower pole. Many years ago, I would say difficult to know if it's a benign design or just a filling defect related to a urothelial carcinoma. You see that when you go in with a digital endoscope, you realize that in fact it's just a simple cyst fixed in between two papillae, very easy to fulgurate with laser technology, and then you will see on the next CT that the picture just disappears. It's another example. Again, you have a filling defect in the lower pole. This patient was a woman. She was a smoker with an history of bladder tumor. What do you do if you have no endoscopic evaluation? Difficult to make the right decision. In fact, it's a very similar case, and when you go in, you see just a cyst from the mucosa. Again, easy to treat, to fulgurate. So there's no discussion actually that the endoscopic evaluation should be part of the evaluation of this kind of patient. Now we have, regarding the guidelines, what we call the low risk and the high risk patient regarding urothelial tumor for the upper tract. We need to consider the low risk patient for conservative treatment. So it means, if we summarize, it's for the ideal case, a unifocal tumor less than 2 centimeters and low grade. That's the main criteria actually to consider the conservative treatment. Follow-up is absolutely essential, and you need to clearly explain this very strict follow-up to your patient before you go for conservative treatment. It's not just one shot. The patient will have to be back many times and regularly for endoscopic evaluation, including UroCT and cytology, of course, but a lot of endoscopic evaluation. It's also now acceptable that if the patient presents some recurrence, to stay with the conservative treatment and just to follow the patient with conservative treatment. And some years ago, we were thinking that after one recurrence, we were supposed to come back to the gold standard, so the radical treatment. In terms of results, we know that high-grade tumor are definitively not the best candidate for conservative treatment. We should reserve this treatment to low-grade tumor. This is the most important criteria when you select patients for conservative treatment. In terms of technique, you know that Bagley and Grasso, they were one of the first to describe this conservative treatment, and they already described the no-touch technique. What does it mean? It means that you need to minimize the trauma of the collecting system when you do the endoscopy. So it means no safety wire, no dilatation of the ureter. Try to use an adequate endoscopes to respect the anatomy and try to avoid ureteral access sheath. Usually we start with a regular cystoscopy. It's very important to check the bladder at the same time before we go up into the kidney. And this no-touch technique means that you are using your flexible ureteroscope to perform a flexible cystoscopy. And when you are into the bladder, you have to respect this sequence in terms of movement just to engage directly the ureter. So it means that first you have to rotate the scope, to torque the scope, to see the ureteral orifice. When you see it, you deflect. You deflect to place the orifice just in front of you in the middle of the screen. And when the ureteral orifice is on the middle of the screen, as you can see now on the video, you just push the endoscope to engage the ureter. It's a not very difficult technique to engage the ureter. Of course, if the ureteral orifice is a little bit narrow, it's a bit difficult to engage. So what you can do is to use a wire, a guide wire, directly in the working channel to engage the distal part of the ureter. As soon as you are inside, you can remove the wire and then you can proceed up to the kidney. Always good to have all the equipment available, so it means semi-rigid or rigid, flexible ureteroscope, including fiber optic and digital, since the fiber optic scope are much smaller, and sometimes, if you have a tight anatomy, you will be very happy to come back to fiber optic. Quality of vision is absolutely essential. There's no discussion that if you are still using fiber optic, as we did until 2007, that's the quality of vision. You can see something, but it's not perfect. And during the treatment, it will be probably difficult to see all the small tumor if you're using fiber optic. So the preferred endoscope should not be fiber optic. When you do the conservative treatment, we recommend actually to use the digital technology, which is actually the best to make diagnostic procedure and perfect evaluation of the collecting system. If you look at these results coming from Bagley and Grasso, you see that when they are performing a diagnostic procedure, in 13%, they said that it remains unexplained. But you need to remember that when they published this data, they were still using fiber optic endoscopes. They were not using digital. Actually, if you consider to use digital technology, the remaining unexplained procedure are less than 2%, just because of the quality of vision. So we have plenty of digital endoscopes actually, and you should select the one you like, the most appropriate to make the diagnosis. Look at this. This is one of my first example I did in 2007 with my first digital endoscope. At that time, it was the CMI, digital one. It's the same patient. I was using my fiber optic, my Flexic C1 from Storz, and you see the comparative view with digital. I think there's no need to discuss. the big advantage to use actually a digital one. But again, keep in mind to still use fiber optic if the anatomy is a bit difficult, if it's a difficult lower pole access, if it's a very tight anatomy, you will be very happy to come back to the fiber optic. You see, it's an example. Same patient, we are using the fiber optic on the right and the digital on the left. We have to force much more with the digital to access the lower pole compared to the fiber optic. And so just remember that the fiber optic are the best one in terms of manipulation. Another new scarp, I think it's for me a big benefit actually, is the new Puzen 7.5 French. It's a digital one and it's the much smaller one, actually 7.5, so it's comparable to fiber optic endoscope. And I think it's a big benefit actually to use these endoscope together with a small size and again a digital technology. The smallest, the size with smaller, it's also a big advantage in terms of outflow for the irrigation, especially if you're using a uroteal access sheet. Another scarp is the Flexic C1, brand new. It's little bit less than 9 French, but it includes the S technology with the Spectra A and Spectra B technology. So it's the first single-use endoscope including this kind of tool for the conservative treatment. Be careful of the bubbles. If you put some bubbles into the system, you know, it's exactly like in the bladder. If you are bubble on the top, always on the top, of course. If you have a small tumor on the top, it could be missed just because of the bubble. So be careful of that when you do the exploration. You see this is a small tumor at 3 o'clock, but it's inside the bubble, so not very visible if you don't remove the bubble. Irrigation, we already talked about irrigation. Irrigation and of course pressure. This is really something that we don't like when we do conservative treatment. If you crack the system, if you create some urinoma, some extravasation, it's maybe acceptable for stone treatment, but it's absolutely not acceptable when you treat urothelial tumor. So be careful of the pressure, irrigate very slowly, very gently. Respect this pressure to irrigate 40 centimeters and never force irrigation. We have a good biopsy forceps, but you can also use a regular nitinol basket, the one we are using actually to remove fragments. The trick is the following. If the tumor is into the kidney, you can catch the tumor into the kidney and then you pull the basket to the bladder. But if you are into the ureter, be careful after you catch the tumor, be careful to first push, go to the kidney, and then you pull. Why? Because if you have any resistance, and if you pull first, there's a big risk to damage the UPJ and to strip the UPJ. So that's the reason why into the ureter we prefer first to push to the kidney. It's much more safer, and then you come back to the bladder. It's a very small trick. In terms of lasers, we have different lasers. You know holmium YAG. This is the gold standard actually. What do we recommend in terms of setting? For holmium, we recommend first to fix a long pulse duration. Then you follow by the energy, 0.6 to 1 joule. It depends if you prefer to be in contact with the tumor or if you prefer to take some distance. If you take some distance, you need to accept less energy. And frequency, 10 to 15. Cut the tip, as we already mentioned, there's no need to keep the transparent tip. Long pulse, 1 joule, 15 Hertz, that's what I like, or 10 to 15 Hertz. I like 1 joule because I don't make the contact with the tumor. I prefer to activate my laser far away from the tumor and move to the tumor. And when you see it's blanching, you stop and you keep this distance. Also use what we call the lateral effect of the laser. There's no need to be all the time perpendicular to the tumor. Otherwise, there's a risk to perforate, and especially into the ureter. So you can keep the laser fiber parallel to the mucosa, and you use this lateral effect just to destroy the tumor. Thulium YAG, you know thulium YAG, it's also a laser that we are using for the prostate. Few people already validate this laser system into the collecting system. But I think the most interesting new lasers actually is again the thulium fiber. But now, in terms of setting, even you respect the same energy and frequency, 1 joule 10 Hertz, remember to select short pulse. There's no need to go even for the medium or the long pulse. Doesn't make the difference. The benefit of the thulium, it bleeds really not. It's really bloodless. This is a big benefit. But you create more necrotic tissue with the thulium fiber compared to holmium. Holmium, less necrotic, more bleeding. And with the thulium fiber, it's less bleeding, but more necrotic tissue. So that's what we recommend actually in terms of settings, according to holmium or thulium fiber. And again, respect some contact. Possible to do en-bloc resection by using both technology. I much prefer actually the thulium fiber for the en-bloc resection. It works very well. It's super precise, doesn't bleed. This is really something nice, this thulium fiber technology, if you like to do the en-bloc resection. Uroteal access sheath, be careful about that. As you know, there is a big risk to damage the ureter, so never force if you would like to place an access sheath to reduce intrarenal pressure. Why not? But be sure there is no tumor into the ureter and don't force not to damage the mucosa. How to improve detection? XVIX, it exists in the past, coming from Storz, but now it doesn't exist anymore, so it's not possible to use the XVIX with the PDD light into the upper tract, unfortunately, so there is no specific recommendation for PDD, actually. Regarding other technologies, NBI, you probably know the narrowband imaging system. It's an enhanced system developed by Olympus. That's the typical view that you will see on the left. When you switch from white light to NBI, you see this effect, looks like frog's eggs with this black spot in the middle. This is something you will not see if it's just irritation of the mucosa, as you can see on the right, and the stone irritate the UPJ, but you see there's no black spot in the middle of this small papilla. NBI is nice because you can also sometimes detect very small tumor. It was invisible or more or less invisible with the white light. So this is something nice. I will not tell you that NBI is perfect, but it's a very easy tool to be used. Something very comparable coming from Storz, the S technology with different modes. We recommend to use the Spectra A or Spectra B. My preference is Spectra B, but it's a personal preference, just to see a little bit better the tumor and especially the limits of the tumor. But we have no clear data actually to support the benefit. So it's really up to you to use this kind of system. Something personally that I don't like, and I think that nobody knows if we need to consider or not, when you see urothelial tumor covering the papilla, what does it mean? Is it something that we need to assimilate to invasive tumor or not? Personally, I need to tell you that when I see this kind of picture, I'm not really happy to stay with my conservative treatment. And I would recommend my patient probably to go for a radical treatment. OCT, you probably know this technology, optical coherent tomography. Interesting, probably for the research, actually, we cannot actually recommend this technique routinely. Same for the confocal laser endomicroscopy, very interesting technology, useful in gastroenterology. I'm not so sure that for the upper tract it works so well actually. We have very few data, difficult to recommend. What I would strongly recommend to you is to consider a second look very quickly after the first initial treatment. My preference is to do a systematic second look after 4 to 6 weeks to be sure that everything is actually removed. Stage procedure, It's also something we can consider. There's no need to remove all the tumor in one time. Sometimes you need to do two times. Topical treatments, there's very few data actually. Again, very difficult to tell you if we need to consider or not post-operative installations. We have this good data regarding BCG and CIS. We know there's a benefit, but I must say that for the rest, it's a bit difficult to recommend systematic post-operative installation. My take-home message is flexible ureteroscope are very important for the diagnostic and the evaluation. Conservative treatment if patient present low-grade disease. I think, again, this is the most important factor to select the good patient. And in terms of equipment, digital flexible ureteroscope is really essential. We have new tools that we still need to evaluate, but it's sometimes helpful. Consider an early second look after the initial procedure, stage the procedure if you need, and of course we will still need more and more evaluation for the future. Thank you.
Thank you, Prof. Traxler. Over to you, Dr. Daryanto.
My question, maybe any question for the audience first?
I think we're going to have a Q&A for this part because the next two topics are slightly different. So are there any questions from the audience?
Yes, yeah. Any question for the audience? If no question, maybe I want to ask for the Professor Traxler. What kind of the laser you recommended for this procedure, and about the complication?
So what kind of laser?
Yes, sir.
So I used the holmium for more or less 20 years, and I was relatively happy with the technique. It works very well to ablate the tissue, but the main problem was really the bleeding. Sometimes very difficult to control, and if you would like to improve the bleeding with holmium, then you have to irrigate more. But if you irrigate more, you increase the pressure. And if you increase the pressure, intrarenal reflux, you know the problem. So I was not so happy due to this problem. So since 2 years now, I'm using the thulium fiber systematically, and I must say that I'm very happy because the bleeding is almost zero with the thulium fiber. It's really something fantastic, meaning that you can minimize the irrigation and you minimize also the risk of intrarenal reflux. So thulium fiber is great. Just the only disadvantage, it produces a lot of necrotic tissue. So if you have to treat a big tumor, you have also to insist a little bit just to remove the necrotic tissue, something that you will not see with holmium.
Okay, thank you, Prof. Traxler. So in the interest of time, we shall move on to the next speaker. Dr. Daryanto, please, you're going to introduce the next speaker.
Thank you, Dr. Lee. Now the second speaker from Japan by Dr. Kazumi Taguchi. Dr. Tagumi Taguchi was a primary investigator in urology basic research laboratory and supervised research was a postgraduate student in Nagoya City University. He also taught them the skill for basic experiments such as intra-abdominal and tail vein injection in mice, immunohistochemical staining, PCR, and flow cytometry. Dr. Taguchi has conducted and summarized genome-wide analysis of human renal tissue and in vitro or in vivo studies of renal macrophage to develop molecular target crystal dissolution therapy for kidney stone disease. He got several Japanese government grants, and his research won national and international awards. Dr. Taguchi has joined Chai Laboratory since July 2016 to collaborate basic research work and initiate a cross-continent study between UCSF and Nagoya City University. Dr. Taguchi, time is yours.
Professor Duranto. And good morning, everyone. First of all, I'd like to thank everyone who have organized this Congress, especially Doctors Wu, Wade, and Kwok, and my friend Waketam. And my topic here is position for endoscopic combined interventional surgery. I have no potential conflict of interest to report. So before we proceed, I'd like to introduce my city. So this is Japan, and Nagoya is located in the center of Japan, and its population is about 2.5 million, meaning the fourth largest city in Japan, and land area is almost 370 square kilometers. So the population density is similar to Singapore. So we have the same number of doctors per capita, and however, the number of hospital beds is much higher in Singapore. So that's why we are known to be somehow, workaholic Japanese. So, but the good news is the cost of living is less expensive, so you can afford whatever you'd like in Nagoya. So Nagoya has a beautiful castle, aquarium, and unique delicious cuisine. And since it's geographically located in middle, traveling to Osaka, Tokyo, and Kyoto, it's convenient, fast, and comfortable by these bullet trains or Shinkansen. So you should better come to Nagoya. So okay, here we are back to today's topic. So first, I introduce the ethers, the concept and the current understanding. Next, I will compare the prone and the supine. It's actually for the supine, it's actually the modified vertebral position. And lastly, I'd like to take a look at some results from clinical studies. So let's start with the ethers itself. So endoscopic combined interventional surgery, so-called ESES, was reported as a combination of PCNL and ureteroscopy. And as you can see here, it enables simultaneous treatment, facilitating fragmentation and vacuum effect removal from the percutaneous tract. The first appearance of this paper got several editorial comments, so which were controversial, but attracted our attention. There are some pros and cons to ethers. So it has the flexibility to access all caries like ureteroscope, as well as easy stone extraction like PCNL. However, it requires basically two devices and two surgeons above and below, which weighs some burden, cost, and human resource-wise. The clinical application of ESES has been spreading worldwide, starting from Italy and Spain. Japan started ESES in the early stage, and of course, here in Singapore. How about the surgical outcome? So there is a recent systematic review reported by Dr. Scofone, a pioneer of this surgery, summarizing 14 studies that shows 61 to 97% of stone-free rate with 6 to 44% complication rate. And so these case volume in each study were very small, and there is only one randomized control trial. So therefore, we need more prospective data, ideally as a multi-institutional randomized control trial. So in Japan, the ESES cases has been increasing. About 1/4 of the percutaneous procedure was ESES back in 2017. Since then, we had a revision of the medical reimbursement system. So now we can increase 1/3 of revenue for performing ESES. So we are currently building a database and looking for international collaborators such as you. Moving on to the position comparison. So there are two types of patient positioning for ethers: prone split leg and Gardner modified supine vertebral. They both allow percutaneous and ureteroscopic access. However, the question is, which one is better or applied for certain cases? Before coming to the conclusion, let's take a look at some comparisons. So prone has a wider range of puncture site than supine does, and skin to kidney distance is longer in supine than in prone, in particular, middle and lower calyces. And when we look at the CT images, the lower calyx was displaced outward in prone, but not in supine position. How about ergonomics? For ultrasound guidance, holding a US probe is wide and easy in prone, but narrow and difficult in supine. And I personally use a microconvex, the smaller one, for the supine puncture. And for fluoro guidance, the bullseye technique should be used in prone, but in the supine, we need the biframe method, which might be a bit more difficult. And the tracked angle may be tricky, but it tends to be close to 90 degrees like this, yeah, in the prone, whereas it can be almost flat in the supine. And most importantly, in the prone position, we, guys like me, usually have to stand in the prone position, whereas you can sit in the supine position. For the ureteroscopy, we cannot use a semi-rigid scope in the prone position, obviously, and there are some differences in ureter and kidney anatomy, which I will show you later. And additionally, manipulation of ureteroscope angle is the opposite. So this is a virtual reality simulation in the prone position. And as you can see here, proximal ureter and UPJ are falling down by gravity. And while we are finding a path into the lower calyx, there was enough space under the 12th rib. And this one is a supine position of same patient, but the proximal ureter is above the UPJ and looks close to straight. And when we were trying to puncture either the upper calyx between the ribs or the lower calyx, they looked, parallel to the floor. But for the lower calyx puncture, the pelvis was close to the puncture line, so it may be, block your tract moving. So these are the biggest differences from the virtual reality views. Lastly, I'd like to show some data from our clinical studies. So this was a multi-institutional retrospective study we conducted a few years ago. We compared prone split leg with Gardner modified supine position as supine vertebral position. So 218 cases in hospital from a SMART study group. This was led by the doctors Inoue, Hamamoto, and Okada, were collected. And we first performed the ureteroscopy with a ureter access sheath, then punctured into the kidney under the ultrasonic guidance, under the ultrasound guidance, then inserted the percutaneous tract. And finally, performed the percutaneous procedure combined with retrograde intervenous surgery. So here are the surgical outcomes. So there were no differences in stone-free rate between the two groups. But superimposition had a statistically longer surgical time, but decreased the febrile UTI development. Then we focused on this fever instance. So we did a multivariate analysis for factors associated with postoperative fever. In addition to the longer surgical time and positive urine culture, prone position was an independent factor associated with postoperative fever. However, since this was a retrospective fashion, so there were some limitations need to be improved. So next, we try to understand the clinical difference between those two positions. We conducted a single-center randomized controlled trial. Patients who needed ethers due to the large linear stones were enrolled in the study. After this block randomization, cases were allocated to the either prone or the supine group. And finally, we analyzed 46 cases in the prone position and 43 in the supine position. The primary endpoint was set for stone-free rate. So since this was a randomized control trial, no difference was seen in patients' backgrounds between the two groups. So the stone-free rate did not differ between the two groups, and there were no differences in other surgical outcomes, except for the percutaneous access-related complication, such as hematoma, boil, or thoracic injury. During the study, we collected surgeons' feedback using a questionnaire, and the result shows that ultrasound visibility and puncture operability scores were higher in prone, meaning superimposition might be more challenging, especially for residents and fellows. Moreover, when we performed the sub-analysis divided by each calyx, the superimposition was first for the upper calyx puncture. However, most of the percutaneous access-related complications were from the upper calyx puncture in the superimposition. So caution is recommended. So to sum up, ESS is of course practical and efficient as long as you have proper resources. Prone-split dead and Gardner-modified supra-invardivia positions are both major, and I would recommend starting ethers in the prone position if you do not have enough experience. And finally, better to choose either position for either case depending on access location. And to do that, we need to understand both features, prone and position, and know your equipment, your skills well. Thank you very much for your attention.
Thank you very, very much for your nice presentation, and also thank you very much for your sharing knowledge. Now, the third speaker, introduced by Dr. Lee, please.
Professor Isla Munji, who is a consultant urologist with the International Islamic University in Kuantan, Pahang. He's an expert in treatment of urinary stones and has also published widely in a variety of topics, including the impact of COVID on surgery. So without further delay, let's go on to his presentation, which will be a virtual one.
Thank you very much for your kind invitations. I'm going to talk about new technologies in lithotripsy for PCNL. So there is evolution of endourological treatment for urolithiasis. Retrogradely, we can approach the stones, and antegradely, we can approach the stones. We have this rigid URS, flexible URS, and then we have this standard PCNL to mini PCNL. We change the position from prone to supine, and then we combine both approach to get the E-cells, and sometimes we use the flexible nephroscope as the intraoperative nephroscope. There is also the evolution of the size of nephroscope leading to evolution of the PCNL techniques. So the scope becomes smaller, and then we have this standard PCNL, mini PCNL, ultra mini PCNL, mini micro PCNL, and macro PCNL. That is the reason why we need a good lithotripter with the new techniques that we have. So I'm going to talk about the past, the present, and the futures of the lithotripters. The lithotripters start with this pneumatic and electrohydraulic lithotripter, such as the Swiss lithoclass, and then we have the single probe ultrasonic lithotripter, such as the Olympus LUS2. We have the dual probe, dual modality EMS lithoclass master and Olympus Cyber 1. The difference between this lithoclass master and Cyber 1 is that the lithoclass master has the lithoclass at the center, while the Cyber 1 has the lithoclass action at the periphery. Then we have the single probe dual modality, the Olympus Shock Pulse SE, and the EMS lithoclass trilogies. Not to forget the lasers, mainly the holmium lasers and the new thulium lasers. This is the Swiss lithoclass at the top, and at the right bottom is the lithoclass master, and at the left bottom is the shock pulse. So this lithoclass use the compressed air, which later have these mechanical fragmentations. The problem with lithoclass, it is retrovulsions. This is the history of the EMS lithoclass. You have in 1991, the Swiss lithoclass, which is the first lithoclass. And then in 2001, we have the Swiss lithoclass masters. In 2005, we have the Swiss lithoclass 2. And then later we have, in 2018, the latest Swiss lithoclass trilogy. How about the Olympus ultrasonic lithotripters? We have LUS2, which is the single probe ultrasonic lithotripters, and then the Cyber 1, the two probe dual modalities, and the shock pulse, which is the single probes dual modality. Ultrasonic lithotripter use the piezo ceramic crystals, which later convert the electric energy into mechanical energies, and then become the ultrasonic wave, and later transmit to the tips to vibrate, and the stone is fragmented. So it is war between the Olympus and war between the EMS. In the past, the Olympus Cyber 1 versus EMS lithoclass masters. Now we have Olympus Shock Pulse SE versus EMS lithoclass trilogy. So this is the Shock Pulse SE, the Olympus Shock Pulse SE, which is a very easy system, plug and play, and very easy to set up with a good ergonomics hand activations probes, which is give optimal comfort to the surgeons. And the best thing, we have this suction control wheel in which we can control how much suction that we need. It has a single lumen probe, a white lumens, which can suck out all these fragments of stones. What is more important is the Shock Pulse SE technologies, in which it gives the intermittent shock wave for the hard stones. So how we get the ballistic effects for the hard stone? It is by this spring mechanism inside the probes. How about the trilogy? This EMS lithoclass trilogy. It gets its name from three things. One is the ultrasonic energy management, the second, ballistic impact, and the third is the suction capacities. So it gets this ballistic effect from the electromagnetics technology, which generates the ballistic effects. What is interesting about the Swiss lithoclass trilogy is the range of probes. We have these evolutions of techniques of PCNL, the mini PCNLs. Then some of people may do the mini PCNL in prone position where there is a problem in taking out the stones. So this trilogy has the advantage by many size of probes down to the one that we can use for the mini PCNLs. So, but the only disadvantage, it is a single-use probes in comparison to shock pulse, which is reusable probes. Not many studies compare this shock pulse and trilogies, but in conclusion, this is a study in Journal of Endourology, Research Study 2021. Both trilogy and shock pulse is highly efficient at removing large stones, but there is slight advantage of trilogy in the efficiency, safety, and reliabilities, especially in case of device malfunctions. This is per Theodor Clave, which is a Swedish mineralogist. Is very important in endourology because he is the one who found these holmium and thulium elements in 1879. Holmium is actually a Latin word for Stockholm's, which is holmia, and thulium is actually coming from Thule or Ultima Thule is Greek word for Scandinavia. So this is the latest laser system, the Moses and also the thulium laser. Laser, you know, which is the light amplification by stimulated emission of radiation. It is actually light. So if you look at the spectrum of light, on the left extreme is the ultraviolets, on the right extreme is the infrared. We can only see light at the wavelength of 400 to 700. So ultraviolet and infrared cannot be seen. This holmium laser is in the infrared spectrum and thulium laser also, where holmium laser has 2100 nanometer wavelengths and thulium is 1940 nanometer wavelengths. How holmium is produced is in a box where you have this flash lamp, the krypton and xenon, going into the crystal, which has these holmiums, yttrium, aluminums, and garnet, and produce the holmium, which is transmitted through the surgical fibers. To increase the frequency, we need more box. While thulium is produced by diode laser through fibers in which there is a thulium elements, and then comes up and we use the surgical fibers as this to transmit the thulium lasers. So there are wide choice of holmium laser system in which the most popular nowadays, the Luminis Moses technologies. So this is the Luminis Moses technologies. It is a very powerful, high power watt, 120 watts, high frequency up till 100 to 120 hertz. But you can see that the range of energy is not so much, from 0.2 to 6 joules. It has short, medium, and long bulk width. But the other disadvantage of this is actually it needs a very, looking at this Moses technology. So it is not the same as Moses effects. Moses effect, actually all the lasers are using the Moses effect. Moses technology actually deliver the first bubbles in which it separates the fluids, and the second bubble which ablate the stones. So it significantly increase the efficiency and reduce the retropulsions. So this is the bench test in which it shows that the Moses is better than the regular holmiums, but there is a limitation of this holmium. With the advancements of Moses technology, it is very difficult to create a faster than laser, and also to have a more smaller fragments. So that's why this thulium laser comes into field from Olympus. This thulium laser have the range of fibers up till 100 down till 150 microns. So people thought, why we need these small fibers in PCNL? Yes, we need it because all these advance in evolution of techniques that you use the flexible RIRS for ESERs, and you do intraoperative nephroscope. How many times you see, but when you put the laser, you cannot reach the stone. So this is very important. So it creates a very low energies. The range of energy is from 0.0 to 5. So it creates a smaller fragments. It is very fast. It can go up to 2,400 hertz. And more important, it can be used with 100 volts outlets. So not many study compare these two also, the thulium. This is comparison in ureteroscopy. But in conclusion, they say that this thulium laser significantly has highest stone-free rates and shorter operation times, and reduce the intraoperative complications. Lithoclast versus ultrasonics versus lasers. Definitely lithoclast not used as a combination. Laser is very good with holmium, but this is my own case. The laser doesn't work at all with stone matrix. So, but when you use this ultra probes, you can see that it sucks very easily the stone matrix. So this is my opinion. Laser is good for micro UMP mini perk because of its small fibers. It's good in supine because of the gravity effect. So you don't have, so the fragment will comes out with the gravities. Ultrasonic is good in prone position because you need these suction mechanisms in large stones. So because ultrasonic is quite big, the lumens. Lithoclash is good in hard stone. Usually it is used as combination with the ultrasonics. So, but nowadays with all this evolution of mini perk, so can we do prone position with lasers? Yes, of course you can do, but it is a little bit difficult with laser because you have to take out. But nowadays is no problem. You have that trilogy with small probes, and you have this PCNL suction handpiece for the Moses technologies. If you don't have that, this Cleopatra nephrostomy sheath is good because it has that suction mechanism at the side of the sheath. So the take-home message, there is no single technique or equipment outscore the others. So you have to use the right technique at the right situation, at the right time, at the right place, with the right patient and with the right equipment. The evolution of different techniques most likely will increase possibilities of personalized approach. So you have to use the right method for right patients. So whatever it is, this is my centers. I still use this Richard Wolf Dresden PCNL scopes, 24 French sheath, and sometimes the standard PCNL scopes with 26 to 30 French sheath. And for mini PCNL, I use the pediatric nephroscopes, the Richard Wolf. I use Cobra for ESAs and intraoperative nephroscope flexible cystoscope of Richard Wolf. I talk about this shock pulse, lithoclash trilogies, thuliums, but you have to use what you have in your centers. I use the lithoclash masters and the 50-watt Origa XL. So what is important is that you master your weapons, you know what machine that you are using and get the best outcome from it. Ansan is the gold medalist in archery. Ina Dariglazova is the gold medalist in fencing. Ansan cannot beat Ina Dariglazova in fencing. He's good in archery. But Ina also cannot beat Ansan in archery. So you have to master your weapons. So this is the more important in PCNL. It is actually more personalized approach in which you have your individual clinical expertise, patient's preference, values, and expectation, and best available clinical evidence to get the improved patient outcomes. Whatever it is, the most important, I think this is what I believe, that you should at least have your standard weapons and know how to use the other weapon. If you can master all the weapon is good. Like this samurai is good in swords, but can use the bow, or this commando used in machine gun and can use the revolvers. This is Kuantan, my place. You can come anytime. Thank you very much.
Thank you, Dr. Munji. I think we still have time for Q&A. There's a question for Professor Traxler. So could you join us on the stage? Thanks. Whether you recommend stenting after ablation and biopsy using the no-touch technique?
I think it depends of the size of the biopsy, if it's bleeding or not. But to be honest, I'm not afraid to stent my patient after conservative treatments. I know some people are thinking that we can maybe spread some tumor cells to the bladder. But if you think, I don't know if it's very well demonstrated, but for sure, you know, when the patient presents a urothelial tumor into the kidney, there is some natural spreading of the cells every day to the bladder. So I think if you need to place a stent, don't hesitate to place a stent again for a few days. There's no need to leave it for a long time.
So related to that, I would like to ask if do you practice the use of BCG or mitomycin, you know, with a DJ stent to allow it to reflux?
Yeah, that's a concept. You know, we did many times this post-operative installation through the bladder using the reflux with the double G. The problem is that which volume do you need to instillate in the bladder to generate the reflux? If the bladder is completely empty, if you put, for example, 40 milliliters of mitomycin, there's no reflux. So what we did in the past, we did the first installation with contrast to generate this reflux and to calculate the volume. And most of the time you need to instillate 120, 150 to fill the bladder just to initiate the reflux. And the reflux, we demonstrate in more than 60-70% of patients. So for some patients, there's no reflux, even with a double G. So it's very difficult to give you a strict protocol how to instillate using double G and reflux. I think if you would like really to put something into the collecting system, the best way is to use a uroteal catheter that you connect outside and then you instillate.
Thank you. There's a question for Dr. Taguchi about whether, so in your own personal practice, do you tend to prefer prone or modified supine for ECIRS?
Yes. We do make a choice before we decided to is a position, but so we personally, and I would prefer for the supine position if we had to make a upper calyces puncture. Yeah, because for the upper calyces puncture, supine is more close and anatomically, and it's easy to reach out into the renal collecting system. But for the lower pole or the middle pole puncture, maybe I would proceed with the prone puncture. Yeah, it depends on the patient and depends on where you want to put the tract in.
Thank you. Just add on to that. So in Japan, what is the ratio of prone to supine PCNL? Just rough ratio.
Rough explanation. Okay, yeah, that would be difficult to estimate. But for our university, so we're studying supine ethers back in 2019, and these days probably 40% is the supine and 60% is still prone. And because maybe similar to the other urologists, other countries, we studied from the prone position, and we are kind of used to the prone. And not every institution has studied the supine puncture.
Are there any questions from the floor? If not, I have one quick question for Dr. Munji. So in your take-home message, you recommended that for mini PCNL, lasers are recommended, over, for example, shock pulse. Have you actually tried using those smaller shock pulse probes, like 5 French?
I haven't tried actually. Honestly speaking, I have not tried with this shock pulse. But the reason that I recommend the lasers because of this gravity effects. Because when you have the lasers, a lot of time the problem in a prone position when you use lasers, you have sometimes even if it's not dusted, there is a small fragments that you have to pick out. That is the reason when I suggest, it is my opinion actually, it's not the take-home message. It's my opinion that I believe that lasers is very good in supine positions, but with this advantage of new technologies like the small shock pulse and also the trilogies, maybe with this advantage of suction mechanisms, then it can be also used with this supine position. Because before this, we don't have these small probes, but nowadays we have small probes which we can use with the mini PCNL. So, but the other thing that I experience with these supine positions, that you have to balance between the pressure inside the intrarenal cavities. Because if the pressure is too low, sometimes that will affect the visualability of your scopes. So you have to balance between that. Thank you.
Okay, thank you very much. So I think if there are no questions from the floor, it's time for lunch.
Is there time for one more question from virtual here. It's Ben Chu here. Just a question for Dr. Traxler. What do you suggest, maybe I missed it, for follow-up of the upper tract urothelial carcinomas? Sometimes the CT urograms may not be as sensitive, and particularly if it's a larger tumor. Do you go back up and have a look at a certain time? And if so, what do you do?
No, yes, it's a very big question, important question regarding conservative. If you look at the guidelines, the European guidelines, for example, they really recommend the follow-up according to what we do for bladder tumor. It's a little bit copy exactly of the same, more or less. I think we need probably to do something more specific. My first recommendation is, of course, endoscopy. UroCT regularly, I can tell you, is negative. And when I go up to the kidney with my endoscope, I see some lesions. So yes, it's good to do CT because if you have a big tumor, you will not miss it. But for the small one, I'm not very, very happy with my UroCT. So I think endoscopy is very essential. It's just a personal recommendation. I would say I prefer to do more endoscopy than less. So sometimes I know that maybe I do a little bit too much. For example, when the guidelines recommend to do the check at 6 months or at 1 year, I prefer to do it at 4 months and 9 months. So a little bit before. Doing like that, I think you take no risk for the patient until we will know exactly the good recommendations.
Mm-hmm. Thank you.
Thank you, Prof. Traxler. So I think it's time to break for lunch. Thank you, everybody.